So the topic for presentation is about the pH, which is the definition, measurement, and importance and maintenance of pH in the body, sir. So to start with the definition of pH, it is the negative logarithm where the base 10 of hydrogen ion concentration, which is pH is equal to minus log 10 of hydrogen ions, sir. So the pH measures the hydrogen on a logarithmic scale, where a change of 1 pH unit is going to be a 10-fold change in the hydrogen ions in the body. The pH, the body's pH is tightly regulated because the enzyme kinetics, membrane potentials, and protein structure are usually pH sensitive, sir. So based for the measurement purposes, ABG analyzer is going to be the gold standard measurement for pH measurements, and ABG uses a glass electrode, which is also a pH electrode, which measures the potential difference, which is going to be proportional to the hydrogen ion activity compared with the reference electrode. Also, we can see the venous or capillary blood ABGs, capillary or venous blood sample, where ABG is not available, but the values might differ from the arterial around 0.03 to 0.05 units, which will be lower. And the many a times the heparin or air bubbles or delay or any temperature variations can also affect the measured pH. So the sample that are taken has to be avoided to exposure to air and maintain at correct temperature whenever required. So the importance of maintaining the pH is firstly the enzyme function and the metabolism, where any small pH changes can alter the enzymatic reactions happening in the body. Oxygen delivery, where the pH shift of the pH shifts the oxygen hemoglobin dissociation curve to the right, which means enhanced oxygen delivery happens there due to the Bohr's effect. And the cardiac function, where if the patient is in acidosis, decreases the myocardial contractility and predisposes the patients to arrhythmias, and even severe alkalosis can also provoke arrhythmias and coronary vasoconstriction. In the neurology, the acidosis can lead to cerebral vasodilatation, where there will be an increased cerebral blood flow and also an increased intracranial pressures. Similarly, the alkalosis can lead to vasoconstriction, where there will be a decreased cerebral blood flow, and the chance of cerebral ischemia can also be there. Electrolytes and drugs, where the acidosis causes an extracellular shift of potassium, and the pH usually determines the ionization of the drugs, where for example the local anesthetics, where unionized fraction usually crosses the membranes. In the perioperative period, the acid-base balance is going to tell us about the ventilatory strategy, the fluid choice, and transfusion management, resuscitation, are also during sepsis and massive blood transfusion and liver renal failure and other surgeries. So the main disorders that can occur with the pH imbalances are, to start with, the respiratory disorders, where the PaCO2 is the primary abnormality happening here, where the increase in the PaCO2 will cause respiratory acidosis, where the patient is in some of the examples where the patient this might occur is hypoventilation, some airway obstruction, COPD exacerbation, and respiratory muscle fatigue or sedative or opiates, or a severe chest wall disease. Just to the opposite of it, the respiratory alkalosis, where there is going to be a decrease in the PaCO2, which can occur due to hyperventilation or any mechanical overventilation. These hyperventilation, in the sense the patient might be in anxiety, pain, or even a high altitude. These things, the respiratory alkalosis can be there. Moving on to metabolic disorders, here the bicarbonate is the primary abnormality. The metabolic acidosis, there's going to be a decrease in the bicarbonate levels in the body, where there is an increased acid or a loss of bicarbonate. Both leads to a decrease in bicarbonate levels. Here they have a subtype called high anion gap metabolic acidosis, which is usually we call with the mud piles acronym, or methanol-uremia, DKA, propylene glycol, or paraldehyde, or fenformin as poisoning, or iron or ionized lactic acidosis, ethylene glycol, and salicylates. Normal anion gap metabolic acidosis is which is usually due to GI bicarbonate loss, wherein diarrhea or renal tubular acidosis or POP after a large saline infusion. The last one is the metabolic acidosis, where there's going to be an increase in the bicarbonate levels in these patients. We can see this with patients with volume contraction or vomiting or gastric suctioning or diuretics, hyperaldosteronism or exogenous bicarbonate infusion. The compensatory mechanisms happen, the maintenance of the compensatory mechanisms in these patients would be for a respiratory compensation will happen for metabolic disturbances, which can happen within minutes. So for metabolic acidosis, if the hyperventilation can reduce the PaCO2 values. Similarly, for metabolic alkalosis, hyperventilation can raise the PaCO2, which is limited due to the hypoxemia risk factors. Similarly, renal compensation for respiratory disturbances, which is usually slow compared to the respiratory compensation, and this can take from hours to days. So respiratory acidosis, the kidneys increase the hydrogen excretion and bicarbonate reabsorption or generation. Wherein in the respiratory alkalosis, the kidney is going to excrete the bicarbonate levels, and reduce the hydrogen excretion. So as a rule of thumb, for every acute respiratory acidosis, the bicarbonate levels are going to rise about 1 milli equivalent per liter for every 10 mmHg of increase in PaCO2 values. Similarly, for chronic respiratory acidosis, the bicarbonate values are going to be more by 3.5 to 4 milli equivalents per liter per 10 mmHg of increase in the PaCO2 values. Also, in acute respiratory alkalosis, there's going to be decrease in the bicarbonate values around 2 milli equivalents per liter per 10 mmHg of PaCO2 values. And for chronic respiratory alkalosis, the bicarbonate values will be decreased by 4 to 5 milli equivalents per liter for every 10 millimeters of mercury mmHg of PaCO2 values. The compensation is the metabolic acidosis, where we can expect the PaCO2 values to be 1.5 times of the bicarbonate values plus 8 plus or minus 2, which is also called as the Winter's formula, where we can test for the respiratory compensation. So during the perioperative implications of the pH values are in the preoperative period, we need to identify if the patient has any acute or any chronic disorders. Chronic respiratory acidosis wherein COPD will have a renal compensation where their baseline bicarbonate is going to be higher, and uncorrected severe acidemia, where if the patient has a pH of less than 7.2, it's going to increase the perioperative risk, where the patient will have an increased risk for myocardial impaired myocardial contractility and increased risk for arrhythmias, and also a decreased response for catecholamines, and they should be priorly optimized before taking for surgeries. During the intraoperative period, ventilation strategy must be taken care of, like adjusting the minute ventilation to target the PaCO2 depending upon the clinical situation, either permissive hypercapnia or normocapnia. And fluids should be large volumes of normal saline should be avoided, and balanced crystalloid solutions are preferred whenever appropriate. Massive transfusion, we need to watch out for metabolic alkalosis and then acidosis, wherein due to hypoperfusion or lactates. And acidosis effects on drugs will be the local anesthetic ionization is the main issue here, and there's a decreased response to vasopressors, and also altered pharmacokinetics can also be seen. In the post-operative period or in the ICU, we need to treat the underlying cause, wherein if the patient is in sepsis, then the source control is the major treatment option. Also, hypoventilation in ventilatory support can be done. Bicarbonate therapy can be given to the patients cautiously whenever needed. And coexisting electrolyte abnormalities should be treated carefully. Thank you, sir.
You finished?
Yes, sir.
I think you have approached this question from the more of a pathological variations in pH. But usually this question is asked as a basic science question where how normal pH is maintained in the body.
Okay,
I
sir.
think you have not dealt anything about it at all. Did you mention anything about the buffer system, the respiratory system, and the renal mechanisms of maintaining a normal pH between 7.35 and 7.45?
No, sir.
That is because if it is asked in the basic science paper, that is the main answer that is expected. What you have described is all various clinical pathological conditions where pH gets altered and how you are dealing with that. Okay.
Okay, sir.
So if it is a question in the first day or second day paper, the basic sciences, then you have answer should be more how it is and how it is measured. I think the part of the question is how is it measured also is given. So you have to say write something about the pH electrode, how it is functioning, how it is getting measured in the ABG machine, and what are the other options for measuring the pH. That also has to be included. So I'll just show my PPT of how to do that.